morning, sir. Good morning, everybody. My wishes to all the delegates. Thanks for the invite, and congratulations to the Telangana ASI and Dr. Pallam Praveen. Double congratulations to Dr. Pallam Praveen because of his acceptance of his paper. And a big, huge applause to all the people who are involved in this, particularly the upgraded Department of General Surgery, starting up from PGs to OT boys, assistants, professors, everybody took wonderful care so that this sort of a Fistula is happening. It's not usual to have 650 delegates. So I am Dr. Reginald. I'll be talking about sphincter repair and flaps in Fistula and Ano. See, for the past some time, since yesterday, we've been talking about all the things about sphincter and all the stuff and fistulas and treatment of fistulas. This is so because the topic is fistulas. So in and out, we'll be talking about fistulas and anatomies of fistula, pathophysiology of the fistula, and lots of things match in our talks. But then everybody has their own viewpoint, their own research, their own way of telling it. So I hope I could make some sense out of this. So the procedure to repair or reconstruct a damaged or weakened sphincter muscle is known as sphincteroplasty. The components of internal anal sphincter, the components of anal sphincter are internal anal sphincter, which is about 2 to 3 thickness. This is the extension of the circular muscle, and it is responsible for 70 to 85% of resting anal tone. Whereas the other one is external anal sphincter, which is about 8 to 10 mm thick. It is divided into 3, subcutaneous, superficial and deep. It is voluntary in control, and the innervation is pudendal nerve. Anything which happens to the pudendal nerve, patient gets into incontinence. That's where we need to check out whether it is because of the breach in the components of the sphincters or it is because of the neuropathy or anything else which is happening with the pudendal nerve. And here we are able to see the deep, superficial and subcutaneous. This is one important slide which I love to present because you can see in the intersphincteric area there is a CLM. It is the longitudinal muscles of the rectum which is coming down, which is going medially and also laterally into the internal sphincter and also into the external sphincter, and ends up with the muscles in the subcutaneous area. This shows the integrity of the internal and external sphincter. They don't behave all by themselves separately. There is an integrity between all the sphincters. The deeper part of the external sphincter goes and becomes the part of the puborectalis, and the puborectalis goes and becomes a part of the levator ani. All the things together work tandemly. Anything, anywhere is going to have a problem. And here you are able to see that particular anorectal angle, which is usually around 90 degrees. This is because of the U-shaped sling of the levator ani muscle group. That is the puborectalis. And here we find all the components. You can see the puborectalis, deep external sphincter, superficial sphincter, subcutaneous, and superficial and subcutaneous. You can also see here that these are the things which also form the walls of the urethra and vagina. So whenever there is a breach, you can see patchless vagina also. Immediately post repair, if you have observed, suddenly the vagina takes up its own shape again. That is the reason, because the sphincters which are coming out are also here. There are other supporting structures like perineal body, anorectal mucosa and hemorrhoidal plexus and pelvic floor muscles. We have urogenital and anorectal triangles which also form the perineal body. And what are the most common cause of the breach in the sphincter complex? The most common cause in the breach in the sphincter complex is the obstetrical anal sphincter injuries, which is known as oasis. Then depending on the breach, they are divided into class 1 to 4th degree, 1st degree to 4th degree. If at all they are entering the sphincter complex, they start off from 3A, 3B, 3C and 4th, and that's how they are classified. And the other causes of breach in the sphincter complex is the traumatic and iatrogenic. Traumatic bulgur injuries, which are still common, which I did last month also. Then RTS and other traumas, and then iatrogenic injuries like fistulotomy, fistulectomy, hemorrhoids, particularly PPH, lateral internal sphincterotomies, anorectal abscess drainage, and rectal process surgery, particularly SAR. These are prone to have incontinence. They breach the things. Then again, there are other causes like rectal prolapse, neurological conditions, and inflammatory bowel disorders and radiation proctitis. How do we diagnose? It's the medical history, then the examination, and then the special tests like ultrasound, like endoanal or 3D transperineal, and we have MRIs, MRI diffeography, electromyopathies, and proactive tests. They are there. And what are the risk factors for this recurrence and incontinence? Are diabetes, prior abscess, complex anatomy, improper post-operative instructions and follow-up. Fistulotomy also increases incontinence risk. There is what is known as conservative management. There is a consensus that before you just get into the repair, we are supposed to do conservative management. Frankly speaking, I have never come across this until unless I was sitting and preparing. So there is what is known as a sacral neuromodular modulation, which is supposed to be the first line of surgical option for patients with fecal incontinence with or without sphincter defects. There are other conservative managements like posterior tibial electrostimulation, magnetic anal ring, radio frequency, bulky agents like fat, and most recent advances like stem cell therapy, which are nascent, but they are promising that they can make up the sphincters, and then biofeedback. Transanal irrigation is one which helps us to restore regular bowel movement. So there are also other related procedures, just like the person who just spoke before me about the dynamic graciloplasty, and there are also gluteoplasty, but they have their own complications with them. There is one particular algorithm. So after taking history, if at all there is graded incontinence, we actually go for surgery. But if the incontinence is only for stools and not for and the patient is continent fetus, we will not go for surgery. We will try for only for medical management. And if at all there is an injury to both EAS and IAS, that is external anal sphincter, internal anal sphincter, and more of the puborectal is involved, the procedure of the posterior is compromised. If the injury is to the external anal sphincter but the internal sphincter is intact, the procedure gives a good result. Whereas the other way around, again, IAS injury with or without EAS, also sort of it's compromised, and it also can also come up with some good procedures. Preoperative bowel preparation, it all depends on individual surgeons. Oral laxatives, low fibers. There's one paper which said mechanical bowel preparation and with oral antibiotics reduce surgical site infection. So antibiotic prophylaxis and particularly patient consent about other things and alternate modalities. Perioperative also in ASRCS and SAGES also said that we need to have antibiotics. What is the technique? There are two techniques basically. One is overlap sphincterotomy end-to-end. End-to-end is usually in primary repair. Overlap is usually tried in the secondary repair. But there is a paper which says there is no significant difference between overlapping and end-to-end surgical techniques. You can see there. The one in the left side is a picture where the figure of 8, but as a matter of fact, figure of 8 is not supposed to be used because it strangulates the blood supply. It is always the box sutures which are supposed to be used. And the most commonly used suture material is PDS 3O for EAS and 3O and 4O for the internal anal suture. This is the another type of suturing. Then the positioning is either in lithotomy on jackknife. And preoperative endoscopy helps, intraoperative endoscopy helps, but as surgeons, your finger is your scope. Your eyes are your fingers, and you are going to see your thing there. That's where exactly what we are doing that. We palpate, we check out where is that breach and all those things. In spite of all the technology, as a surgeon, you sit and you check it out. Palpation. Then you go with an curvilinear incision about 180 to 200. The very important thing is you don't go too much into third 3 o'clock and 9 o'clock space because there is neurovascular bundles there. So we need to be very careful as far as the neurovascular bundles there. We are not supposed to injure those things, and accurate sharp dissection is very much needed. The mucosa can be sutured with 3O or 4O PDS or sometimes Vicryl. I actually use Vicryl. It could be continuous or intermittent. If it is intermittent or continuous, the distance between the suture should be anywhere around 0.5 centimeters. This is how it is. Yeah, if at all we are able to separate both internal sphincter and external sphincter and do it, it gives a better result. But there are times when we will not be able to do it. So don't try, force and tear it away, because as I told you, it is a one complex which are working together tandem. So try to go together. So the dividends of the muscles are united by an either overlap technique or interrupted sutures. Here it says it is better to obtain a good union rather than to risk everything by trying to produce a textbook overlap with undue tension, which again causes necrosis and again infection. These are the steps which I have already said. This is again, see, all the things have been getting out from the papers. Not necessary to identify internal and external anal sphincter. Preserve some fibers if at all there is some scar tissue so that there is some vascularity. Excess mobilization is not to be done because it causes denervation, and it is bit tighter is always better than having a loose patulous repair. Post-operatively, early mobilization to prevent thromboembolism, then gentle rectal examination later on in about a week or so. Sitz baths, laxatives, low fiber, sexual intercourse after 3 months. If at all it's a woman, put her on progesterone not to get any periods. Pelvic floor rehabilitation after about 2 months. Some of the complications which are seen post-operative are skin dehiscence, then post-operative pain, hematomas, urinary retention, perineal abscess. The guidelines say that moderate to severe fecal incontinence due to isolated sphincter defects about less than 90 to 180 degrees, go ahead and do primary repair. Obstetrics also say that we can go and do it in oasis also. This is very important for everybody. This was something good for me actually. They say figure of 8 is not to be done, box stitch is good. Sphincter stitches should not be very tight, they should be snugly fitting. If possible, try to do overriding sutures, but it is not necessary. Eliminate the spaces for proper suturing. Dead spaces accumulate fluid and trigger infection. Distance between the two mucosal sutures should be about half a centimeter. While suturing the anal canal, speculum should be good enough so that you maintain proper, you don't get a narrowing of the anal canal. All knots should be facing away from the lumen. If at all the defect is about more than 25%, there is always the chance of dehiscence. So try to mobilize, but don't injure the neurovascular thing. Don't close the skin. This is what I follow. Then we have CRD which is placed there. Recognize local sepsis so that the sutures are safe, and ask patient not to squat. Gentle movements will help. There are other things like trapezius and lift which are known as sphincter preserving things. If at all there is function, bowel function has a problem and the patient is multiparous, always try to go for sphincter saving surgeries. The outcomes, immediate outcome is about 74. Actually, we even got about 90 to 100% of success rate. But then it says that over the time it goes down. So the results in obstetrical injuries are even much better than the other results, like because of the iatrogenic injuries like fistula nano or because of the trauma. Quality of life is one thing which we need to assess. So these are the citations for all the things which I've been talking about. Coming to the next part of my talk, flap surgeries. There are two particular flap surgeries. The reason for flap surgery is it is a sphincter sparing alternative, aims to close the internal opening, and primary goal is to prevent the persistence of contamination. There are two things. One is the endorectal advancement flap, the other one is dermal advancement flap. Either way you advance onto the either from inside out and or outside in, so that you can just cover up the internal opening. By covering the internal opening of the fistula, we are going to achieve a prevention of the contamination. So inside the anal canal there is a high pressure, so it is good, and then again it basically helps in low recurrence rates, like only 20% has been seen. I'm not getting into it. This is how a mucosal flap is done. Either mucosa, submucosa, or a part of the muscle can also be taken up. The part at the internal sphincter is narrower, and the distal part is much broader, so that we have proper blood supply. You cross over the internal sphincter and then close it beyond the line, so that it is well taken up, not before the line. And the same thing with the dermal advancement flap. You can see here, either you can make an elliptical incision and then pull it inside. Then again, that's how you close, but there's a raw area which can heal by secondary intention. These dermal flaps can also be, instead of having an elliptical flap, you can also make an advanced VY-plasty, or you can also make a house flap. This is how it is. But this particular slide is very important, because this is known as Cleveland fecal incontinence score. From the time you see the patient, you should have multiple number of slides, papers like this, which tell us what exactly is the progress of the patient, whether he is still incontinent, is still continuing to be there, or is going to become better. This is one very important slide to share. Thank you.